Respiratory emergencies, probably one of the most important chapters in this book. You have to get this. Everything we do has some sort of respiratory connection. How in the heck do I mean that? Does every patient have asthma or emphysema? Or no, but you have to monitor and attempt to maintain respiratory status of your patients. If you have a shock patient who, and remember, shock is inadequate perfusion of tissues, and you have a patient who's in shock, you have to monitor their respiratory system and how the respiratory system is impacting the rest of the body. So what could we do respiratory wise for a shock patient if they're not perfusing well, and maybe we initially think their rate and depth and of respirations is fine, and that seems okay, but as we monitor them, as we reassess, it starts to look like their perfusion status is decreasing even more. We're blowing plenty of oxygen into them, right? Or we're providing it for them, not blowing it into them. We have that non-rebreather, 15 liters per minute. There should be plenty of oxygen available for diffusion to take place in those capillary beds in the alveoli and oxygenate our patient, right? But there may be an issue that is preventing that process. How can we help? We can assign somebody on our team to either take over and completely breathe for that patient or assist their respirations. Here's a rule of thumb, and I don't state this nearly as eloquently as Paul Whitfield, but I'm going to give it my best shot anyway. If you have a patient with an abnormality in rate of respirations, rhythm of respirations, or depth of respirations, coupled with signs of shock, you need to provide positive pressure ventilation. All right, I told you it wouldn't be as eloquent as Paul, but you haven't heard Paul say that. So it's just one of those things that Paul rattles off in his sleep. But let's break that down, because that's the major foundation of what we're doing this morning. So let's start with signs and symptoms of shock. Are all of our respiratory patients in shock? Maybe. Not all of them, but our critical ones, maybe. If we just go with that basic definition of inadequate perfusion, then yeah, these respiratory patients who are in these critical respiratory patients, they may be showing signs and symptoms of shock. Maybe their level of consciousness, they're conscious, but they're confused, slightly combative. That confused and slightly combative, that could be that sign of poor perfusion of the brain, right? So we need to, number one, hurry and get some oxygen on that patient, but we may need to get more aggressive really quickly. Just like if you have a patient with an arterial spurter of their femoral artery, we don't wait to see if that's going to stop bleeding. Yeah, it's going to stop bleeding when they run out of blood. So we get a tourniquet on that right away. Respiratory wise, if we have a patient with inadequate perfusion, we need to provide positive pressure ventilation quickly if it's indicated. And so watch their rate and depth of respirations, and that's going, and then watch their perfusion status. So keep those things in mind as we go through this chapter, but we don't wait. If they're poorly perfused, we're not going to wait for a long time to see how they do on a non-rebreather. If they have inadequate perfusion and that non-rebreather doesn't change things really quickly, then we're going to get after the positive pressure ventilation. All right. Standard competencies. Let's see if there's anything in there we need to worry about. Anatomy, signs, symptoms, and management of respiratory emergencies, including those that affect the upper airway and the lower airway. Did they leave anything out? No, that's our two divisions. Remember that the larynx, the vocal cords, the vocal cords are in the larynx, the structure of the larynx. Anything above that's upper airway, anything below is lower airway. Anatomy and physiology, I'm going to go through some of this as we go through these slides, because I want to make sure I don't miss any definitions that maybe I need to touch on a little stronger than I do others. That brings up a point. Sorry, I didn't mention this earlier, but so we'll go through these first few slides, which I normally delete, but I thought there might be some terms that we need to talk about. So anatomy, epiglottis, you know what that is. Okay, epiglottitis. Let's read. Not only do you have to know the definition of words, you have to read them and understand what the word is, or the definition does you no good. Okay, we'll talk about epiglottitis, that disease process. We'll talk about spontaneous pneumothorax. We've talked about pneumothorax resulting from trauma to the chest. We've briefly talked about that. It is possible to be in the friendly confines of your home, kicked back in your recliner, watching a ball game, and pow, you have a spontaneous pneumothorax. It's semi-rare, I guess you'd say. That's all right. Pulmonary edema, talk about that as we go. Asthma, and then COPD. We'll extend that on into this chapter into environmental and industrial exposures. Oh man, there is some stuff out there that's wicked, and we are not going to be able to commit to memory each and every one. Industrial exposure, number one, if you don't know that scene's safe, or if you get in there, you respond to a possible heart attack call. And they thought this guy was having a heart attack because he was kind of clutching his chest and having a really hard time breathing. And then he's down on the floor and struggling. And somebody thinks that must be a heart attack. And it turns out that it was some sort of toxic gas exposure or an environmental exposure. And at that point, you need to withdraw, get the heck out of Dodge, tell them to get him out in the fresh air, but get away from there until what? Until you can call for additional resources, which would be the fire department, and hazmat, and then hazmat crew to come clear that scene, make sure it's safe for you. Then we'll talk about toxic gas, pertussis, whooping cough, cystic fibrosis. It doesn't have a different name. And then pulmonary embolism. That's its name. That was funny, right? Since I defined pertussis, rough crowd, man. I don't hear any laughter. Greta's snoring over here. It's just tough room. All right, pneumonia and then viral respiratory infections. Dyspnea. I think you know what that term means by now, but shortness of breath, difficulty breathing. Remember when we talked about in the medical terminology chapter, actually, when we talked about documentation and the need for caution with abbreviations that you throw in. And I told you that at least in the old days that shortness of breath was abbreviated SOB, and that caused some problems for some reason. I don't really know what triggered all that when people get upset about being an SOB or having SOB. Excuse me. What causes dyspnea? Tons of stuff. We'll talk about some of them. Is it our job to determine what is wrong with each and every patient? Big headings, we can usually narrow down the cause of dyspnea. Sometimes not, but we may arrive on scene and have a patient who is extremely dyspneic, and we spend almost all of our time with that patient just trying to manage their airway and the rate and depth of respiration. So we're down possibly to positive pressure ventilation, and we're trying to fight the Grim Reaper and keep him kicked back so he doesn't snatch away the soul of our patient. So we can't determine every time what the cause of shortness of breath is. Does that change our treatment? No, not at a critical level. We need to provide ventilations for this patient, or we need to provide sufficient oxygenation via the appropriate delivery device to maintain their perfusion, right? That's the goal of our respiratory management all the way around, is to maintain perfusion. Okay, respiratory system, you know what the system is. It's all the pieces, parts that contribute to your breathing, right? How in the world did diaphragm not get highlighted, turned red, and bolded like everything else? Strange things happen in tornadoes. And here, this had nothing to do with the tornado. Okay, diaphragm. Remember all this. We've gone over it and over it and over it. Why? Because it's important, right? When your body gets the nerve signal that you need to breathe, that triggers contraction of the diaphragm. The phrenic nerve innervates the diaphragm. That signal reaches the diaphragm, and what does it do? It contracts just like any other muscle when it receives an electrical impulse conducted along a nerve or nerve pathways. And what happens when a muscle receives that signal? It contracts, right? And then when it ceases to receive that signal, it relaxes. So the diaphragm, through its innervation, I use that term all the time. I guess I should define that. Innervation is the nervous system connection of a muscle to the spinal cord, or muscle to directly via the cranial nerves. It's an electrical connection. That's innervate. So that muscle receives its signal from the same place every time in normal operation of the body, and that signal travels until it reaches the end target that where contraction is indicated or desired. So that's what I mean by the phrenic nerve innervates the diaphragm, and that when that signal arrives, the diaphragm contracts, it flattens out. So that just created a larger interthoracic space. That's cool. But then we combine contraction of the intercostal muscles, and that moves the ribs, right? So that moves the ribs up and out at the same time. So that has opened up that thoracic cavity, and by making that larger, that has lowered the pressure within the chest. And by lowering the pressure, that creates a pressure gradient so that air from the outside will flow from the area of higher pressure to the area of lower pressure. And then that gets air through the bronchotracheal tree, and that gets air down all the way to the alveoli for that gas exchange to take place, right? Also, accessory muscles of breathing, the abdomen, and then the neck. So in respiratory distress, we'll see the person overusing those accessory muscles as they fight to try to breathe. And then nerves to the muscles, that's the innervation. Okay, upper airway above the vocal cords. There's your laundry list. You should know those by now. Let's see, how many of those did you know before you got here? First two, or first three: nose, mouth, jaw. You thought you had an inside of your mouth before you got here, maybe, and now you have an oral cavity. Oral cavity is more important, right? Sounds much more prestigious. So we go to the dentist and discuss our teeth that lie within our oral cavity. And then in the posterior, or the back part of that oral cavity, we find the pharynx. We have an oropharynx and a nasopharynx, right? Naso, nose, oro, mouth. So that's the pharynx. They come together in the posterior, the back of your throat. We'll just talk like real people for a minute, right? And then your larynx, that is what you used to call your voice box, right? That more prominent in men because of testosterone causes greater development of that cartilage and makes that much more prominent. And by making that larger and making the vocal cords longer, those vocal cords are capable of much lower pitches than the smaller, tighter vocal cords found in people with 2X chromosomes instead of an X and a Y. X and a Y would be biologic male, and 2X's would be a biologic female. That picture should be really familiar. Now, you know why they put all the same picture in here over and over? And they and then they use the same text for the most part over and over and over, it adds pages. When you add pages, what happens? The cost of the book goes up. That's my jaded opinion of that anyway. Principal function of the lungs in respiration is exchange of gases, right? Exchange of oxygen and carbon dioxide. Let's slow down for just a second as we make our trek down eventually to the alveoli. Remember that after your trachea bifurcates, what is that bifurcation? That area of anatomy, it's called the carina, C-H-A-R-I-N-A, carina, divides into bronchi. You have a right main stem bronchus and a left main stem bronchus. That's what we call those two airways after that division. So when you hear people, in true confession time, I guess, man, when I was in EMT class and I was brand new to this terminology, when I heard people talking about the right main stem bronchus, left main stem bronchus, I'm thinking that, man, those are different structures than what I memorized in anatomy class, because I never heard that terminology before. They're talking about the same thing, the right bronchus and the left bronchus. It's just that main part of that upside down tree of airway passages. So don't get too hung up on that. I think when you get to the distal portion of the bronchi, right as it starts to branch out and become the bronchioles, then just like a tree branching out, it gets a little fuzzy maybe as to whether I'm in the distal bronchi or I'm down to the proximal bronchioles. And I'm using distal and proximal. So the distal portion of a bronchus would be that area furthest away from the origin of that structure. So that very distal end of a bronchus branches out and becomes the proximal or the beginning section of the bronchioles. The bronchioles, those are smaller airways. Remember, we talked about the other day in that asthma is a reactive airway disease in the bronchioles. So what changes between the bronchi and the bronchioles? Oh, the cartilaginous rings go away. So bronchioles have smooth muscle surrounding them, and the lumen, or the inside portion of the tube, the lumen expands and contracts with the contraction or relaxation of those smooth muscles around the bronchioles. So when I say reactive airway disease, the smooth muscles of those bronchioles react to some sort of stimulus or maybe a trigger we'll talk about in a few minutes with asthma, and that changes the inside diameter of the bronchioles. So it reacts to something in the environment or something internally. So that's bronchioles. If you have a little bit better picture of that now, you have that smooth muscle tube without cartilaginous rings in it. What are cartilaginous rings? They're rings of cartilage. And without that, that can squeeze down or open up. And then alveoli, that's where the magic happens. We've talked about it ad nauseum. You're nauseous of hearing me say ad nauseum, right? I didn't know ad nauseum until I got to law school. And I thought it was pretty cool because I thought, man, I could have saved paragraph after paragraph after paragraph if I could have just used 2 Latin words that I didn't know yet. Have some pictures of alveoli again, or for a little repetition from before. I am losing my voice, so I apologize, folks. Everything's falling apart this morning. Inspiration, expiration, oxygen is provided to the blood, carbon dioxide is removed. You remember what causes all this to take place? Diffusion, right? Because of the difference in partial pressure in the partial pressure of gases. What gases? Oxygen and carbon dioxide. And through diffusion, those molecules move from an area of higher pressure to an area of lower pressure. That's the diffusion. And then in the alveoli, you have, or there in the alveoli where we are, you have coming through in single file, if you can picture those capillary beds being that small in those alveoli, oxygen is coming through, or the blood is coming through, and those red blood cells, as we're talking, these capillary beds can be as small as 1 red blood cell at a time, and you're providing, if we're supplementing oxygen, we have lots of oxygen available, oxygen molecules, and as those red blood cells come through with empty hemoglobin, then an oxygen molecule can jump on or attach to one of those hemoglobin molecules on the red blood cell. All right, I told you there was a picture. I didn't do a good job of building it up and getting you excited about seeing a picture, right? Oh man, I shouldn't do that with my voice. There's that bronchial. There's the old smooth muscle I was talking about. Down here with these capillaries, that's where gas exchange takes place. And see how those red blood cells are pretty much lined up single file. They're trying to cut in line because they're trying to push over the top of each other. I don't know for sure that that's what it looks like. I've seen books with pictures that look different. But I mean, we're down there in extremely small vasculature, and we have all these oxygen molecules coming in, all these carbon dioxide molecules, and we have that exchange. This is out in the tissue. So we have oxygen molecules moving out into the tissue, carbon dioxide moving back into the bloodstream, and then some of this carbon dioxide attaches to hemoglobin, some of it just rides along out in the blood itself. All right, there's our, okay, that should be enough of that. Make sure I did not miss anything. Okay. We know what happens in those capillaries. The oxygen moves into the capillaries, and then from the venules, carbon dioxide moves out, and that is where the oxygenation takes place. Also called, where was I going? Capillary perfusion. Okay, we talked about the brainstem controlling the rate and depth of respirations. That should sound vaguely familiar at this point. And this oxygen exchange, gas exchange in the alveoli can be hindered, could be by anatomy of the airway. It could be that there's a genetic disorder that causes that patient to have difficulty in their lower airway, upper airway, all the way down to possibly having an underlying condition that interferes with the airway. Then you can have disease processes that interfere. Two that come to mind really quickly are what? Asthma and COPD. Traumatic conditions. We'll spend some time in the chest trauma chapter talking about pulmonary asphyxia, someone who receives a major blow to the chest and they have traumatic asphyxia. That's what I'm trying to say. And because of that massive trauma to the chest, that alters some of the anatomy of the lower airway, and that leads to insufficient alveolar respiration, leads to inability to create that through the expansion of the chest, the inability to create that pressure gradient so that the normal tidal volume comes in to make its way down for oxygenation. Excuse me. Then abnormalities in pulmonary vessels. We'll talk about briefly in a minute, talk about pulmonary hypertension. Didn't know your lungs should have high blood pressure, right? The pulmonary arteries that lead to your lungs as that deoxygenated blood is ejected by the right ventricle and moves into the pulmonary arteries. That's what I'm talking about. A person can have higher pressure than normal in their pulmonary arteries, which causes difficulty in circulating blood through the pulmonary arteries and out into the lungs. So the heart has to work harder because it has to push against that pressure, right? So that is pulmonary hypertension. Incidentally, Viagra, Cialis, those kind of, well, it was originally just Viagra. Viagra wasn't developed for the purpose that you see, or the indication, now that we've done pharmacology, the indication for the administration of Viagra wasn't originally what you see being advertised on TV. That was, I guess, a fortuitous side effect of the administration of Viagra. Because as they were studying a medication to treat pulmonary hypertension, to try to open up those pulmonary arteries and decrease that pressure within that pulmonary artery, they found that the male patients had a side effect that could be quite lucrative for them. So pulmonary hypertension, you can thank for somebody making tons of money out there off of various medications that are still used to treat pulmonary hypertension. All right, we have to recognize signs and symptoms of inadequate breathing. That's only half of the equation, right? Then you have to know what to do about it. That's kind of why you came here, right? No, I took this class so I can be an EMT and so that I can be a professional firefighter at the end of this thing. Okay, but a big part of what we do here and what you will do as a firefighter is to manage medical patients, trauma patients. So we have to know the signs and symptoms of inadequate breathing. Then we have to know how to treat it. So today we're going to talk about multiple conditions that create signs and symptoms of inadequate breathing. Some patients have chronic carbon dioxide retention, and the book says we need to be careful about administering oxygen to them. We'll talk about who that is and why in a minute. Patients exhibit dyspnea dyspnea and hypoxia with the following conditions, that's not an exhaustive list: pulmonary edema, hay fever. I am a horrible hay fever sufferer, and those who don't have it can never understand what it's like for those of us who do. And most people are thinking just a little bit of runny nose and itchy eyes, but it can go a lot further than that, and it can trigger dyspnea. So don't just completely discount a condition because it sounds like, oh, that's a little bitty deal, because in some people, it can be an extremely big deal. All right. Pleural effusion, then obstructions of the airway, hyperventilation syndrome, those environmental and industrial exposures, drug overdoses, obstruction of gas exchange, damage to the alveoli. That would sure do it, wouldn't it? Obstructed airway passages, air passages, and that could either be upper airway. You probably don't even know what a Tinker toy is. I don't know. A piece of a Lego block lodged down in the upper airway, or this could be obstructed air passages from secretions or blood that need to be suctioned out. Could be obstructed airway passages from the old reactive airway disease that I was talking about. Bronchioles are constricted because of asthma. Then poor blood flow to the lungs, right? We have obstructed blood flow going to the lungs, that pulmonary embolism that I mentioned. Talk more about those in a little bit. And then excess fluid in the pleural space. All right. Signs and symptoms. Patient tells you, I can't breathe. I can't breathe. I can't breathe. Or feel really short of breath. That's what your patient says. So that patient is having a symptom, right? When they're telling you they can't breathe, they're feeling like they can't breathe, and they're communicating that to you. Altered mental status. Last week in patient assessment, I kept over and over talking about patients with altered mental status not being able to protect their airway. So we have to do that for them. Anxiousness or restlessness, those are agitation, inappropriate agitation. They're combative. They're seem like they're just pissed off at something that almost doesn't exist, and they're trying to fight it, and they're trying to fight you, and they're fighting you when you're trying to put the O2 mask on them. Those can be major signs of inadequate breathing. So stay on top of that. And then with kiddos, with the pediatric patients, they sometimes they seem overly sleepy, and they just listless. They're not responding to their environment. Maybe they're not totally unconscious yet, but they don't react to things that a kid would normally react to. One, for instance, would be if you're monkeying around with their head. If you're assessing a pediatric patient's head and they don't react to you in any way whatsoever, my advice to you is go to airway and breathing first, because there could well be something wrong there that you need to address. Or it could be that the kiddo got into mom or dad's Vicodin that they're taking after back surgery. But the first place to start is the thing that's going to kill them right now, and that would be airway and breathing together. That's our respiratory system assessment. And then whether respiratory rate's too fast or too slow, breathing rhythm is irregular. So if the rate, depth, and rhythm of respirations is abnormal and our patient exhibits signs and or symptoms of poor perfusion, then we need to start doing something about that rate, rhythm, and depth problem of respirations. And we just happen to have the coolest little thing. I don't know if you've ever seen one. It has this mask thing, and it has this big bag thing, and it always gets called a bag valve mask, but we can't figure out what the valve thing is. There used to physically be a valve that was the third piece that was totally separate from the mask and the bag, and you had to put them together there at that valve. So I think ours at the college may have an integrated valve and bag, but that's all right. You get the picture now. So we have this cool tool called a BVM that we use for positive pressure ventilation. So I'm going to bag them, right? So when I say bag your patient from now on, that doesn't mean find a great big bag and put them in there and tie it up and set them out by the curb for them to come pick up. That means bag them. That means breathe for them. That means provide positive pressure ventilation. Excuse me. Adventitious breath sounds. Holy smokes. We got a new big word, right? Adventitious breath sounds. Those are abnormal breath sounds. Wheezing, gurgling, snoring, crowing, making a kind of sound. Stridor, high pitch, barking type sound. Those are signs of something major going on with the respiratory system of our patient, and we need to assess and determine if there's anything we need to do about it. We need to auscultate both sides of the chest to assess breath sounds, to see if they're equal bilaterally. We need to assess all lung fields. That's in a medical patient if we have a little more time to assess all lung fields. Excuse me. We need to auscultate and assess both sides of the chest. We're listening for for equal breath sounds bilaterally, noting if they're diminished on one side or another or the other. That's a clinical term for less volume, lower volume in the breath sounds from one side to the other, diminished breath sounds. That is the term that is used clinically with patients across the board in medicine in the U.S. anyway. I've not had the pleasure of, I listened to some lectures online from a doctor who is from somewhere in the United Kingdom, and it's a stretch sometimes to figure out what he's talking about, even in the most basic things, because he uses terminology general terminology in ways I'm not familiar with. So I have to kind of stretch to get from point A to point B. Whether your patient is speaking in beautiful, long, best oratory you've ever heard, or speaking in those eloquent sentences, or whether your patient is saying, I can't breathe, that can tell you a lot about the respiratory status of your patient. Tough question. Was the first one or the second one the patient with dyspnea? Yeah, well, you might go out on a limb and say the second, right? Okay. We're going to be looking for accessory muscle use, retractions. Are the intercostal muscles pulling down between the ribs because this patient is fighting so hard to breathe? And then watch for unequal chest expansion, excessive coughing. Is that patient seated in the tripod position? They're sitting straight upright, leaning forward with their hands on their knees, fighting to try to breathe. And I'm exaggerating it, but those neck muscles, are they contracting those neck muscles, those accessory muscles? Why do they do that? They don't even really know they're doing it, but they do that because if you contract the sternocleidomastoid muscle enough, right here, SCM, everything has an abbreviation and an acronym now. If you contract that enough, it pulls up on the clavicles. Why is that important? When you're fighting to create that pressure gradient, if you can contract that sternocleidomastoid muscle enough, it pulls the clavicles up and it makes that space larger in the thoracic cavity. So they've boosted slightly the development of that pressure gradient. So that contraction has helped lower the interthoracic pressure to try to facilitate more tidal volume moving into the lungs. So that is why they're doing it, and they don't know that's why they're doing it, but that's that accessory muscle use. So and then pursed lip breathing. What are they doing when they do that? By making the opening to the outside world smaller with the lips, that increases PEEP, positive end expiratory pressure. Last week we talked about using a device called, I just spaced out, folks, CPAP, oh, using CPAP to provide PEEP, and PEEP was that back pressure that helped keep the alveoli inflated. So if our patient is pursed lip breathing, they're trying to boost their own PEEP by increasing the back pressure there slightly. All right. Nasal flaring, just trying to open up those nasal passages to get more air into that posterior nasopharynx. People don't, you can exert positive or exert conscious control over those things. Otherwise, I couldn't demonstrate them to you. But when somebody is dyspneic, that is part of the body's reactive system to react to a problem to help remedy that problem. What do we call it when the body tries to remedy a problem or does remedy a problem? The body is trying to return to homeostasis, everything working together for the good of the entire patient. Let's bounce through a few of these and then I'll let you stretch your legs in a minute. Other things of dyspnea, they're complaining of chest tightness or air hunger. Air hunger is when they're just, you can just see them fighting to try to get more air into their respiratory system. That one's more difficult to define, turns out, is for me. These are common with cardiopulmonary disease. When the patient's in distress with cardiopulmonary diseases, pain can cause rapid shallow breathing. If I am in pain, then I may be tachypnic. My rate may be too fast because I'm in pain. And let's say I have rib fractures. Maybe I have a couple of fractured ribs because of the way I was tackled playing football. Been many years since I played football, so we would have to have a very delayed response here for that to apply to me. But if I had a car wreck and I had a couple of fractured ribs, the pain, thanks for handling that for me, Nicole. The pain of the intercostal muscles contracting causes dyspnea. They don't want to breathe as deeply. That is very normal with rib fractures. And in our geriatric patients who suffer a fall and have fractured ribs, that's often the beginning of the end because it hurts to breathe deeply, so they're not going to breathe deeply, and they easily develop pneumonia, and then that infectious process ends up killing them. You see that all too frequently. My own mother-in-law, loved her like another mother, and that's what happened to her. She had a fall, and she nailed her chest on the coffee table on the way down, a table that we had been trying to convince my father-in-law and mother-in-law needed to be removed from that room for a long time. She was 94 when she died, and at least a good 10 years we've been trying to get my father-in-law to allow us to get that coffee table out of there. I'm not blaming my mother-in-law's death on my father-in-law, but those kinds of hazards in you're in your elderly family member's environment, those can easily be the beginning of the end for them, either from striking their head when they fall or have a syncopal episode resulting in a fall, or they get their feet tangled up in something, maybe their oxygen tubing, who knows, but that those things that they could impact in a fall, just like you childproof your home when you have a baby who becomes a toddler and all these little tables you have to move out of the way or out of the room. We also need to do that with our elderly family members, if at all possible. Sometimes it's such a source of contention. You have a little couple who are steadily losing more and more control over their lives and control over their self-determination. So they push back hard on the least little thing, and taking a table out of the room can become that thing. But my mother-in-law fell, lost her balance, and I don't know why she let go of her walker when she lost her balance. You would think you would hang on more tightly, but she fell and impacted the corner of that coffee table, and she had like 3 broken ribs. It wasn't a flail chest because it was just 3 ribs broken in one place, but the pain of taking a deep breath was such that she was not going to take deep breaths. And you even frequently, in a patient with rib fractures, they will send them home with a spirometer that measures the flow of air in a respiration. Most people think they're supposed to blow the thing, and it makes you have a cylinder that goes vertically that has markings on it all the way up to 1 liter, I think. You can blow on it and make the little disc go up to the top, and you can peg the thing. That's not what they're looking for. You have to inhale and pull against that spirometer when you inhale and try to get that disc to go up to the desired level, and continue to do that over and over as part of deep breathing exercises. So I just preached a whole sermon based on 2 words in a verse. Sorry. Rap, you can picture it. Chest hurts, you don't want to breathe deeply, so your body says, all right, we'll breathe more rapidly to try to get the same minute volume, or the volume of air in milliliters from each breath, or from tidal volume multiplied times the respiratory rate is minute volume. Remember that? Yes. Yeah. Everybody raised their hand. We all remember that. So that's how the body adjusts to try to maintain minute volume, is when respirations are shallow and that's not enough, and the body kicks in and says, all right, then we'll just breathe more quickly to make up for that lack of tidal volume. Good place to take a break, isn't it? Let's take 5 here, and then we'll come back and move on through some diseases of the upper airway. And upper and lower airway infections. Infectious diseases not only affect the entire body, but they can also infect and create problems in all parts of the airway. Anything from let's say an abscessed tooth that causes edema to the point that, this is hard for me to picture. I just went with the wrong thing for my example, but I'm going to run with it. Let's say there's an abscessed tooth that causes so much swelling that it interferes with, maybe it's one of those very back molars. Let's pick the lower, and that causes swelling to the point that it starts to close up that oral pharynx, because that edema has from that infection, that swelling has grown to the point that it interferes with air coming in and out. So our patient has a major problem. So that's upper airway, and then lower airway. We already talked about about asthma and that narrowing of the bronchioles. It could be that they have an infectious process. They have bronchitis. That should sound familiar to you. Maybe you never thought about what bronchitis really was, but bronchitis is, it's infectious process that causes inflammation or swelling, constriction. Because of the swelling, it narrows that lumen, the inside diameter of that bronchiole, so that it's harder to get air through. And then you have with anything like that it's also going to be an irritant, so it increases the development of secretions. So the secretions coupled with that infectious process, causing swelling, you can get a really considerably narrowed bronchiole, and that affects tidal volume, right? The patient can't move as much air through that bronchiole because it's too small. And then obstructions, just talked about mucus and secretions. That's easy to picture, right? It's just, you have a tube that's more narrow now, and it has all kinds of stuff sticking to the walls and hanging on the walls. And as that stuff builds up on the walls and builds up more and fills up more space, that lumen gets down to, oh man, I can only move a small volume of air through there. So that's what we're talking about. Swelling of upper airway, an allergic reaction. You have that angioedema. Angioedema we'll learn next week maybe. That's that swelling of the face and swelling of the tongue that go with a severe allergic reaction. That also causes swelling in the posterior pharynx. So that could flat out kill somebody, right? And then impaired exchange of the gases in the alveoli. If there's mucus way down there in those terminal airways, all the way down as far as you can go in the alveoli, if there's liquid there, gas doesn't flow through liquid very well without some pressure behind it. So that interferes with the infected alveoli that have the mucus and secretions there occupying that space. That interferes with gas exchange, right? In maybe a few million of the hundreds of millions of alveoli that you have. Croup. We'll spend a lot of time on croup in our pediatric chapter. We're going to touch on it now. It's inflammation and swelling of from an infectious process, inflammation and swelling of the pharynx, larynx, and trachea. They've changed it now. It's laryngeotracheal bronchitis. So that laryngeo, larynx, trachea, laryngeotracheal bronchitis. And that's an infectious process that it greatly interferes with that flow of air that we're patients trying to get down to the alveoli eventually, and then back out again. And because of that inflammatory response with a patient who has croup's caused by a virus, that patient who has croup, that you get inspiratory stridor, expiratory stridor. It begins as expiratory stridor, but have stridor that that's hard for me to do right now. May trigger a coughing fit, which you don't want over this microphone, but so narrow that the air going past makes a similar sound to that. And then when they cough, which they do frequently, it sounds like a seal bark. And if you don't know what a seal bark sounds like, then Google it and listen to some seals bark, and then Google seal bark cough croup, and you will find some audio clips of what that sounds like. I use those in the pediatric chapter. You'll get to hear what those sound like. And maybe we should have those here, but I don't yet. All right, these patients respond really well to humidified oxygen, which we don't have in most ambulances, so we're going to give them supplemental oxygen and keep them comfortable on the ride, which for a lot of them means mom or dad holding them during transport, or caregiver, whatever you want to say. Epiglottitis is a bacterial infection that focuses on it just nails the epiglottis, and it causes that little muscular finger that and remember I showed you a picture of that from a bronchoscope, or no, it was just from a laryngoscope, sorry, from somebody taking the laryngoscope and going down and recording what those structures look like there. And I pointed out the epiglottis as being that little muscular finger-like, or that little finger-like muscle that covers our glottis, opening between our vocal cords. The epiglottis covers the glottis during swallowing, whether it's liquid or solid, and that prevents the aspiration or inadvertently getting whatever, whether it's food or water, inadvertently getting that down into the trachea, which, by the way, triggers a horrendous episode of coughing. It's almost like it was designed that way. It's a protective mechanism in the body. Okay, find these kids in the tripod position and drooling. They can't swallow, and they're generating massive amounts of secretions, and they can't swallow them. And we have to be careful about doing anything to get them out of there, get the secretions out of there, or we can make the problem even worse. So we'll talk about that when we get to that chapter here in a few weeks. Transport them in a position of comfort and provide oxygen. That's all we can do, pretty much. RSV, respiratory syncytial virus. I am probably not pronouncing S. See, that's why we have initials for it. That's why there's an acronym, because they knew that Buddy was going to have trouble saying syncytial, so we just made it RSV. So RSV is an illness of young children, pretty much neonates. That's from birth until 1 month of age. So pretty much in neonates or very young infants. So that's where we're going to find RSV. We'll talk a lot about it toward the end of the book. Infection in the lungs and the airway passages. And quite often these patients are dehydrated because they don't want to, they don't have an appetite, and they're not thirsty. We treat that with humidified oxygen. Again, I made the same mistake somehow. All right. Bronchiolitis results from RSV. Just remember I said it affects an infection in the lungs and airway or respiratory passages. Well, there you go. Bronchiolitis, that is that can result from RSV. Newborns and toddlers, also our elderly population. We've been thinking more about them lately as we talk about that coronavirus and how that's predominantly, I think, probably one of the highest as far as the group with the highest morbidity and mortality rate. Morbidity, really, really sick, and mortality is ain't sick no more because they died, right? That's so morbidity. That's how sick someone is. Mortality, dead. The highest morbidity and mortality from COVID-19 we've seen in our elderly population, particularly those in long-term care facilities. So I added that myself, put it in parentheses and in italics because that was me adding it. According to your book, RSV affects newborns and toddlers. So that is that's what you could expect to be the correct answer on an exam or the National Registry. But in your practice as EMTs, you get out in the world, remember that geriatric population, particularly in long-term care facilities, those aren't the healthy ones, right? In that demographic, that's not the most healthy people. There's enough wrong with them that they couldn't live alone anymore. They couldn't live at home with home health coming to take care of them, or they just, even with a family caregiver, they reach the point that they can't be managed at home, so they had to go to a long-term care facility. So these people are the most compromised of that demographic in their age group, their living situation. So they're already 1 foot hovering over the grave and the other one on a banana peel. So and let's say we go visit Aunt Fanny at the nursing home, and let's say you do, because you're much more likely to have a newborn in your 24-hour day of care, or a toddler, than I am at almost 58 years old, and our kids are in their late 20s. So you're much more likely to be around a newborn or a toddler and contract RSV yourself, and have mild cold-like symptoms, or possibly be asymptomatic. But you go see Aunt Fanny because you love Aunt Fanny. She's great, Aunt Fanny. She was your Grandpa Jim's favorite sister, and you go see Aunt Fanny and you bring RSV with you. Now Aunt Fanny has been exposed, and there's a chance that Aunt Fanny's going to catch RSV, develop bronchiolitis, and pass on to her eternal reward. So that's why I added elderly, because we want to get the full education here, right? All right. Bronchioles, just picture this. You have that tube of that bronchiole. It's just that little pipe right there, and it gets inflamed. So it's kind of irritated and swollen all over. It just inflamed tissue. But when it swells, it doesn't go out like that. It does something that it swells in and takes, I guess it swells out too, but it swells and it starts to occupy part of that lumen of that airway, which wasn't very big to start with. Oh, well, that's bad, right? It's hard to get air through that smaller tube. So much harder. But then let's just make it worse. But wait, there's more. Let's start, let's trigger that smaller tube in that bronchiole to start producing more mucus, and there's more and more and more mucus, and that's dripping off the ceiling and oozing out of the walls and filling up the floor. If you can picture a tubular shaped house, all of that's happening at the same time. So now you got this gooey, icky stuff that makes it even harder for air to pass through. So that's what we're seeing with those bronchioles, and that's why our patient is not being oxygenated well. Bacterial pneumonia, it comes on quickly. Remember this on an exam, and I haven't made this exam yet, but if I remember to, based on your quiz from last week, I think I'll add a quiz in there and everybody gets 100 because Buddy screwed up. How about that? All right. See, it pays for me to screw up sometimes. We'll just fix the quiz. All right. This bacterial pneumonia comes on quickly. It's like I'm feeling pretty good, and then, oh my God, I got a high fever, and I feel like a bus ran me over, but not quite good enough because I'm still here being miserable and suffering because I have bacterial pneumonia. And my friend Bob, who comes over and plays dominoes with me, I don't really have a friend named Bob, and I don't know how to play dominoes, but my friend Bob, who always comes over and plays dominoes with me on Tuesday, he gets to the house, I barely feel like answering the door, much less playing dominoes with Bob. At first he's pissed, right? Because I'm not going to play dominoes with him. But then he sees I don't look too good. I'm sweaty, and my face is red, and I'm fighting to breathe, and I don't seem to be doing a very good job of it. So good old Bob, because he is a good friend, good enough friend that he forgives me for not playing dominoes this week, he calls 911, and you come rolling in, and you start getting your sample history while you're doing your primary survey and your secondary survey, and you ask, how long's this been going on? And I say, now. You say, now? Just started. And Bob pops up, and he says, yeah, I talked to him on the phone this morning when I was getting breakfast. Or we met at Whataburger, because now it's open again, but it's not. We're going to imagine that Whataburger's available for myself and Bob to go over there and have breakfast every morning. And then I went over and had breakfast, and we play dominoes at 2 in the afternoon, because that's our evening, because we're old. So we always play dominoes on Tuesday evening, which is 2 in the afternoon for old people. I'm not quite there yet either, and he comes into this horrible scene. I just look like I'm FTD when he gets there, right? Fixing to die. And he tells, when I can't really talk because I'm coughing too much and all my energy's zapped, I feel horrible. I mean, it's almost as bad as you can get and still be alive. And Bob says, yeah, we ate breakfast at Whataburger this morning. We got there kind of late. This is about 4:30, and he was doing great. He was telling me he was going to kick my butt in Domino's and reminding me of all the other times that he had. And then I get to his house, and boom, here, this is what you have. And I don't know, but you got to save my friend. Everybody else died. It's just the two of us left to play dominoes. So we got that in our sample history, and we remembered, oh, and he's coughing, and it's a productive cough. I mean, he's bringing some stuff up, and he has a high fever. And we remember this lecture day as communicated through this stupid camera in front of me and this headset on my head. We remember pneumonia that comes on quickly. Really, this doesn't come on quite as quickly as my illustration here, but that's okay. It comes on quickly, it hits hard, it hits fast, and we remember this lecture, bacterial pneumonia. Could that be it? Well, you don't have to determine that. That is the job of a physician. You diagnose pneumonia with chest x-ray. So right now, what might we be concerned about if we have a big time respiratory illness in front of us? We're going to be wearing PPE, because what if this is COVID? We can't determine that pre-hospitally. All of these patients with dyspnea and a fever of 100.4, we start to be concerned that they might have COVID-19. So we wear the appropriate PPE. When is the determination going to be made? Sometimes in the ER, when they get a chest x-ray and determine, oh yeah, this is just good old pneumonia, and then they get some sputum, that's the gunk that you cough up, they get some sputum, or the saliva that you spit out, but they get some sputum, and they look at it under a microscope, and holy crap, there we go. There is that bacteria, there is the culprit. This patient needs IV antibiotics and some respiratory care until we can get them better and keep them from dying. Viral pneumonia comes on more gradually, and it is less severe. If you have it, you feel like you're going to die, you feel horrible, but you're as patient assessment wise, viral pneumonia patients are not they don't experience the degree of respiratory distress, profound respiratory distress that goes with bacterial pneumonia. These have, again, like what I mentioned a minute ago and what we've heard with COVID-19, this has an especially hard, tough, high impact, whatever you want to call it, on chronically ill people. Need to assess their temperature, provide airway support, provide supplemental oxygen, and if necessary, positive pressure ventilation, right? Pertussis, whooping cough. It's an airborne bacterial infection that, off the top of my head, I think almost all of you guys are immunized against, or I haven't seen your shot record, so I don't know yet, but so why did I have to get this? That dang thing right here, it says mostly affects children under 6. But I'm not 6, and I had to get that dang vaccine that had pertussis in it. It is possible to get one without pertussis if you're allergic to the pertussis portion of the vaccine. But we can be carriers. We can contract pertussis, have a mild case, or be asymptomatic. There's a common theme here, and that and we can be a carrier, and we can be the vector that delivers that to Aunt Fanny's great grandchild when we go visit our cousin, and we can be the one who carries pertussis into that baby and potentially kill that baby. The patients with pertussis will be febrile. Here's a new term: febrile or febrile. I'm from Borger, so I say febrile, but febrile, that is having a fever. So feverish, I just threw in a new word there. Feverish and exhibit a whoop sound after a coughing attack. And when we do the pediatric chapter, I have a audio clip that I found that has that whoop. We're going to monitor them for dehydration, suction as needed, transport to the correct facility. Oh, good old influenza A and B. Influenza A, we had a pandemic in 2009. That's a familiar word now, right? An epidemic that spreads to the point that it spreads worldwide. We had a pandemic of flu A in 2009, and I helped design and run mass vaccination clinics to bring thousands of people. I'm talking one day at the Amarillo Civic Center, we did 4,000 shots in one 14-hour day. It's a lot of dang shots. We had a lot of nurses doing the shooting. Okay, so we had a pandemic in 2009. Every year, the seasonal flu kills, I mean, a lot more people than this COVID-19 has killed, for sure. I mean, there are years that we lose way over 100,000 people in the U.S. to seasonal flu. So just because there was only one pandemic in the last 20 years doesn't mean that there's not a tremendous impact of flu A every year. If you've ever had the flu, you will agree with these symptoms: fever, cough, sore throat, muscle aches, headache that won't stink and go away, general malaise. There's another new word: malaise. Just that incredible fatigue, so exhausted that you have to think long and hard about making your way 15 feet from your bed to the restroom. Couldn't I wait a while longer? No, you've been waiting a while longer. The last time, for the last 2 hours, you best be getting your butt up and making it, because you're going to go one way or another. It's best to be in the bathroom when it happens, right? Secondary pneumonia that's the big killer with influenza, that you develop that secondary pneumonia. And now we know how that pneumonia kills, right? That infectious process interferes with the ability for that tidal volume from each breath to make its way all the way down into those alveoli for alveolar respiration to take place, so that you have that gas exchange, right? Man, funny how this all comes together pretty early on in the course. I think you guys probably all have that nailed by this point. And then dehydration. Just don't feel like eating or drinking. My throat hurts so bad I don't want to swallow, and my muscles ache so bad I don't want to move to pick up the glass. My head hurts so bad that all I can do is just lie here in bed with my eyes closed in the dark and pray that I don't see some sunlight. And all of those things combine and then have a fever. So diaphoretic, so you're losing fluids there. And all of that just becomes the perfect storm for the Grim Reaper to use pneumonia to take you on out of here. So let's don't do that. Dehydration. TB is a bacterial infection. Everybody who's going to go to clinical has to have TB skin test. And TB was rare in the US 20 years ago. And there are differing opinions on what caused the increase of TB across the U.S. It's a political football that you have one faction who doesn't want to say that immigration to the U.S., even legal immigration, has brought people into our country from countries where TB is endemic. TB is normal operations where these people come from. And I don't say these people to mean it in a derogatory fashion, but you pick a place in the world. We could pick somewhere in Africa. We could pick somewhere in the Middle East. We could pick someone from our continent who's south of our border. And even coming here legally, they may have latent or an underlying TB infection that can be spread. And it didn't completely go away when it wasn't completely eradicated years ago. We just didn't see much of it. And then we saw a pretty decent little uptick as HIV infections increased, which in HIV infection, that immune system is attacked and compromised goes, the ability to fight disease and infection goes down. And then these infections like TB, that bacteria can come in, take hold in that person, and we see TB in places that we wouldn't have seen it for many years. And historically, TB was endemic in the U.S. and it was there were tens of thousands of people, even with a much smaller population. There were tens of thousands, maybe hundreds of thousands of people with TB years ago. And fortunately, we still don't see it as much as they did then. But those HIV infections caused us to start seeing something that we hadn't seen for years, hadn't seen much of for years. So how do these patients present? They present with fever, coughing, fatigue, night sweats, weight loss. Well, man, up to the point that we threw in night sweats, we were talking about those good old flu-like symptoms I mentioned a minute ago. But you add in night sweats and weight loss, then we start thinking tuberculosis. We have to protect ourselves. We wear gloves, we wear eye protection, and we use an N95 respirator. And then we're going to have a protocol that tells us what type of mask to put on the patient. And we've learned, agree or disagree with this widespread use of masks with COVID-19, push that aside. We've learned that there are times that our patient needs to be wearing the respiratory protection in addition to us wearing it to prevent the spread of these airborne pathogens like TB. Sometimes you put an N95 on your patient according to some protocols, and then other protocols say just to put a surgical mask on them. The thing about about tuberculosis is those sets of bacteria. So those cells, those bacterial cells, are much larger than a virus. So N95 is going to stop those. Pulmonary edema. heart muscle can't circulate blood properly because there is inflammation down in the alveoli and in lung tissue, so that blood can't circulate out as well. Fluid builds up, and that pulmonary edema. And we're thinking congestive heart failure here is a great illustration of that. You have you have a condition, let's say in right heart failure, so that the right side of the heart isn't pumping properly. So what does the right side of the heart do? It pumps blood through the pulmonary arteries out to the lungs for oxygenation, right? So if the output from that isn't sufficient, you have a backup in the system, pressure-wise and fluid-wise, back into the superior and inferior vena cava, and then down all the way through the venous side of circulation. And because you have that higher pressure on the venous side, the left ventricle can't push the blood out as easier because the preload has gone up. That back pressure, the preload is too high, and your heart's having to really push hard to pump against that. And when that happens, fluid pushes out of in those capillary beds. Fluid is pushed out through those capillaries, and that fluid then accumulates and becomes a blockage, so that eventually it starts to back up into the airways, and then that person can even start coughing up this frothy blood-tinged sputum. So I usually draw this on the board. That's why I'm struggling so much with this slide, but hopefully you got the picture. There we go. This isn't how I draw it, but with pulmonary edema, that fluid interferes with gas exchange. COPD, chronic obstructive pulmonary disease. We can just make our voice go up and down because that's how vocal cords work, right? I don't know why I had that sing-song kind of tune going there. All right. COPD, it dilates and it disrupts airways and the alveoli. The alveoli they're larger, but they don't, because of the disease process, they don't participate in gas exchange as well. The cause is bronchial obstruction, and that bronchial obstruction puts that back pressure into the alveoli to the point that it damages them. Multiple causes, quite often years of intentionally inducing smoke into the lower airway all the way down to the alveoli, that damages the alveoli. It could be that somebody has a chronic infection, chronic meaning it's ongoing, and it becomes a long-term deal. Have a chronic infection that damages the alveoli and the bronchioles. Could be the inhalation of toxic gas. Back in World War I, which you know nothing of, but probably, but I knew several old men when I was a kid who were World War I vets, and they had experienced chemical warfare. The Germans frequently used mustard gas to try to incapacitate their enemy, and their enemy happened to be the Allied forces to which we belonged, and as part of that group, we deployed millions of soldiers. And it was also trench warfare, so they were dug into these trenches. And when we're talking trenches, picture something 7 or 8 feet deep and 10 feet wide, maybe, and maybe miles long. That mustard gas, they would fire that from artillery pieces mainly, and the shell hits, and then when it explodes, it releases that mustard gas. It's heavier than oxygen, so it spreads along the ground, this vapor cloud of toxic gas, and then it spills over into that trench and settles in there. And it's a horrible thing as they breathed it, and it damaged their lungs. Even the few who weren't smokers experienced horrible damage, and they developed emphysema from it. And they weren't exposed to it over and over for years, right? It was over a fairly short time, but the damage was enough that it caused emphysema in a pretty good percentage of them. Then you couple that with smoking. They sure didn't know about the negative effects of smoking then. So smoking plus mustard gas equals more severe COPD. All right. Emphysema is the most common type of COPD. You lose the elasticity in the lungs. Let's take that down even further. Your patient loses the elasticity in their alveoli. And what does that do? Remember that inhalation, because of that pressure gradient that allows us to move air down into the smallest areas of our lower airway, which would be those alveolar sacs. And then during inhalation, the air moves down and that stretches out, that expands that little grape-like cluster, that little grape-like structure so if it's not as elastic, it can't inflate as much, right? And then it also causes inflamed airways. I don't know, I messed up something there when I was trying to highlight stuff. So I don't know where that smoking word came from. We're missing the word smoking from somewhere. Okay. And most COPD patients, they have elements of both. They have chronic bronchitis or emphysema, chronic bronchitis and emphysema. And as you can see here, because it's perfectly clear that you have normal alveolus and a normal bronchiole, and then it's inflamed, and that inflammation, see, that's narrows that lumen, right? That's what we've been talking about. And when this narrows enough all the way to the right, it causes that alveolus, because we're just talking one, to expand and remain expanded because of air trapping due to that inflammatory process, and mucus over here, and stays stay stretched out long enough, it damages that tissue so it can't snap back to its what would normally be the uninflated status. But because it can't snap back there, it also can't expand when our patient finally does get oxygenated air all the way down into that alveolus. So that's what we're fighting. Okay, patients with pulmonary edema, they're going to have wet lung sounds. Picture that heart failure that I talked about that causes fluid to back up into the lungs. Let's say the left ventricle isn't putting out as much as it's supposed to. So that decrease in stroke volume, that causes fluid to back up in the system so that where the pulmonary veins come back to the left atrium, that left atrium can't empty down to the left ventricle like it's supposed to because of that higher pressure. So it backs up into those pulmonary veins, which are what? The veins, they're the vessels bringing oxygenated blood back to the left atrium. So it backs up there. When it backs up there, where does it go? It backs up into the lungs and eventually down into the alveoli. And then that forces some of that fluid out and through those capillary beds. And when our patient breathes, that's when we hear those wet sounds, which would either be rales, R-A-L-E-S, rales in the normal people language. Crackles is what we call them now. Either be crackles or rhonchi, R-H-O-N-C-H-I, rhonchi, and it's kind of like air bubbling through a liquid. We'll have audio clips later in the cardiac chapter. Patients with COPD have dry lung sounds. So that's especially for national registry and for possibly my exam, which I haven't made yet. The wet lung sound, that's the sign that points you to pulmonary edema, and then trying to determine where the pulmonary edema came from. Or the dry lung sound goes with COPD. So that's your distinction. Okay, I pick up speed. I have to finish this dang chapter. Okay, asthma, hay fever, and anaphylaxis. It's a result of an allergic reaction. That allergic reaction, if it's severe enough, starts to cause swelling in the bronchioles. It starts to cause inflammation in the upper airway, and that interferes with the ability to move oxygenated air down. Asthma. In asthma, there's a normal bronchiole. Have a narrowed bronchiole because of spasm of the smooth muscle around the bronchiole, and then also mucus obstructing the inside. Asthma affects all ages, and the onset of asthma was once thought to be strictly in children to adolescents at 5 to 17 years, and that was the onset. If you didn't have it by then, you weren't going to have it. I don't know who wrote that book, but they were wrong. You have onset at any age, produces that characteristic wheezing sound. And things that cause people to have an asthma attack or an exacerbation of their asthma. Exacerbation means an episode wherein a condition gets a lot worse. That's a good old, we're sitting down over a diet, my Diet Dr. Pepper talking definition. Uh, exacerbation of asthma. Asthma would be the underlying condition. Exacerbation means signs and symptoms suddenly got a lot worse. So asthma attack or exacerbation of asthma is caused by triggers. There are people that if they smell a certain type of cologne or perfume, that triggers an asthma attack. There are people whose asthma is triggered by something they eat or drink. Could be smoke in the air from wildfires in Arizona blowing east, and for the most part you don't even know it's there. You just see kind of a haze, or you see a really pretty pretty colors at sunrise or sunset. Those that may be that there's fine smoke in the air, and breathing that smoke could trigger an asthma attack. It could be breathing cigarette smoke. Exercise can even trigger an asthma attack. Foods, or this is a big one, getting a respiratory infection, get bronchitis from, anyway, developing bronchitis, that infection and inflammation of the bronchioles, that could trigger an asthma attack. Hay fever causes cold-like symptoms, sometimes extremely severe, sometimes very mild. Whatever the allergen is, different people are allergic to different things. What do you see with these patients? You see watery eyes, sometimes their ears hurt, they have copious amounts of nasal secretions. What's that? They're making a lot of snot. Copious means a bunch, and nasal secretions means snot. So that mucous membrane is irritated in their nasopharynx, and that just triggers. At times it can be very thin, and it's almost like a spigot of warm water has been cracked open slightly, so that there's just snot pouring out of the nose, and without proper medication, I'm not going to do anything about it. It's not going to go away for hours, sometimes days. Severe enough allergic reaction can cause an anaphylactic reaction. We have a whole chapter on that, so not going to spend much time there. How do we treat hay fever? We treat an allergic reaction, anaphylactic reaction, with epinephrine, oxygen, and antihistamines. We treat, and you can't administer antihistamines. So that'd be a paramedic thing. Full-blown anaphylactic reaction, we're going to use epinephrine. We're going to add that to the mix. But oxygen and antihistamines are indicated for just the allergic reaction that's less severe, called hay fever. Spontaneous pneumothorax. I promised you we'd do this. Spontaneous pneumothorax is accumulation of air in the pleural space, right? That space between the parietal pleura that lines the thoracic cavity, the visceral pleura that clings to the surface of the lungs, and that's a potential space. Has a little bit of pleural fluid there to prevent problems from friction as that lung expands and contracts. But if air starts to accumulate in that pleural space, we call that a pneumothorax. Most often we think of trauma as the cause. It can also be spontaneous pneumothorax, you primarily see in young, tall males. So we're talking late teenage, very late teenage into the up through the 20s, tall and slender. That's kind of that doesn't mean that other folks can't have this, but predominantly that's what we see. And following like a week or two following a blow to the chest or possibly a respiratory infection, this person, they'll tell you, I was just sitting watching TV and I coughed a little bit, and then boom, I had shortness of breath and I had this pain in my side and I couldn't catch my breath. They don't tell you that in a whole sentence. It comes out in choppy little 2 and 3 word sentences, but they finally convey to you that they were doing fine until that cough, and then they had that sudden onset of shortness of breath, and they have they're dyspneic and they're tachypnic. They're breathing faster, and they are in distress. Have to be really careful about treating this with positive pressure ventilation because of the risk of more exploding alveoli that cause air in that pleural space. So that is, how do we treat it? We treat it with high flow O2, seat them in a position of comfort, and rapid transport to the ER. So infection or maybe trauma causes weakened lung tissue. Breath sounds, in fact, we may not ever pick up on this. We might have kind of an idea that that's what's going on. We need an x-ray. Last time I looked, there aren't any ambulances, at least in our part of the world, with x-ray machines. And also the cool thing, starting to use, oh good Lord. Anyway, we are getting a pre-hospital tool that would allow us to see this, but it's ultrasound. We use a portable ultrasound machine to be able to visualize small portions of the body on the inside. So you kind of have to scan and get a picture, but you can see on x-ray, and I don't have one here, it's in the trauma chapter, but you can see the difference on x-ray between normal lung tissue with all the air moving in and out in the closed system versus out here around the lung and compressing that lung down. If that lung is compressed enough, we start to have unequal breath sounds. And so pneumothorax, it says wound site. We can either picture that somebody has penetrating trauma, which has damaged this lung tissue, or we could picture a spontaneous explosion of part of this lung tissue that caused that. Pleural effusion, that's collection of fluid outside the lung in the thoracic cavity. We're not going to be able to see this pre-hospitally. We're going to treat the symptoms of it. It compresses the lung, so your patient becomes dyspneic. They're having difficulty breathing, shortness of breath. They will tell you that I can't breathe or can't catch my breath. Those kinds of things that, as they convey their symptoms to us, can stem from just irritation that causes that accumulation of fluid, more often it's going to be infection, congestive heart failure, or maybe cancer that's causing that fluid to build up around the lung, and it compresses the lung and it inhibits tidal volume and gas exchange, right? Usually these patients want to be in an upright position, and there'll be a certain position where they don't feel the pain as much, they don't feel the difficulty breathing as much, and that's where they want to be. And we transport them in what's called the position of comfort, right? Wherever they feel most comfortable, whatever eases the pain. Provide high flow O2, if not possibly positive pressure ventilation. This could be a time that we use CPAP. That would be an airway, an oxygenation adjunct, whereby our patient could be seated, but we still have positive pressure ventilation through that CPAP. Airway obstruction, mechanical obstruction. There's a Lego that's down there blocking things, or it could be inflammation, could be secretions, whatever is blocking that airway. We need to get it out, open it up. We have to treat this quickly before we treat anything else other than exsanguination, which would be completely bleeding out. Conscious patients, the obstruction could be caused by aspiration of vomit. Most common airway obstruction is the tongue blocking the airway. Unconscious patients, I'm sorry. In unconscious patients, remember we said the level of consciousness is low on that AVPU scale. They're unable to protect their airway. We have to do it for them. And if they vomit, there's a high risk of aspiration, which is a mechanical obstruction, which can start our patient down that slippery slope toward the grave. So we can use OPA if they'll tolerate it, NPA if they won't. Suction, we have to get this vomit out of the way before we utilize any sort of positive pressure ventilation, if that's what we need to do. If the patient was eating just before their sudden onset of dyspnea, consider a foreign body food obstruction. There's tongue obstructing an airway. Pulmonary embolism, we're almost done with this chapter, and the other one won't take nearly as long. Pulmonary embolism is blood clot that circulates through the venous system, and the origination, where do these things start? Frequently, pulmonary embolism, the blood clot originates in the lower extremities, possibly from remaining seated on a long flight on an airplane without getting up, walking around. You're saying I'm at risk of that right now. We're almost done with this chapter, and we'll take a break and do the other one. But a blood clot, people call it, that blood clot broke off from somewhere. It's not like we normally have blood clots hanging around in our body just waiting to jump out and attack us. So things like someone who has surgery and they don't get up and walk, and they don't keep that arterial blood that circulates, they don't move about, and that motion it facilitates venous return to the heart. So you don't have any blood clots that are building up. But if somebody is sedentary for a long period of time, they don't have that walking action that that maximizes that venous return, and that blood sitting around can start to develop a clot. And when that gets big enough, that clot can pop loose. Maybe the next time they walk, that clot can pop loose and make its way through the right side of the heart, and then become a pulmonary embolism. It blocks off one or more, or at least partially blocks off one of the pulmonary arteries, which is how deoxygenated blood is carried out to the lungs. So that's how a pulmonary embolism cuts off that venous circulation out into the lungs. If it's large enough, it can cause sudden death. A saddle PE is pulmonary embolism. A saddle PE is big enough that it kind of straddles the bifurcation, right, that where the pulmonary artery coming out of the right ventricle, as that splits off with each major branch heading toward one of the lobes of the lung. If it's big enough that it straddles one of those bifurcations and it blocks off all blood flow, maybe even to the whole left side of the upper and lower lobe, which is all you have, the upper and lower lobe of the left lung, it can be severe enough that it causes sudden death. It'd be a big one. These things are much more treatable now than they used to be, but it is a major deal. It is a life-threatening deal. Signs and symptoms: dyspnea, tachycardia, tachypnea, varying degrees of hypoxia. That means that SpO2 starts going down, and the PaO2, which would be the partial pressure of oxygen in arterial oxygen, that starts going down. That is what hypoxia is. And the more extensive this pulmonary embolism is, and the longer it's there, the more profound the hypoxia is, that dropping level of oxygen. That leads to cyanosis, that bluish color of the lips, the nail beds, and then eventually all of the skin gets kind of this bluish hue to it. Acute chest pain. These things, when a PE nails them, and I've talked to people who, on the recovery side, like after they're not about to die in front of me, I've talked to people who've had a PE, and one of them was a paramedic friend of mine. Another was a guy who's partners in some oil leases, but every one of them I talked to, that was a common thing. Just sudden onset of acute chest pain, just horrendous, knock you to your knees kind of chest pain with associated dyspnea. And I'm talking profound dyspnea. I'm not talking it's a little harder to breathe. It's like I'm fighting and I don't feel like I can breathe. Plus that chest pain, there is a possibility that we're dealing with the patient with a pulmonary embolism. It can become acute enough that our patient starts to experience hemoptysis, which is coughing up blood. All right, enough of that one. We'll learn how to treat them later. Hyperventilation, overbreathing to the point that arterial CO2 falls below normal. It could be a sign of a life-threatening illness that's causing them to breathe that quickly. Quite frequent, and that would be respiratory compensation for increasing acidity of the blood and tissues. We call that hypercapnia, that CO2 level going up, and that makes the blood more acidic. As CO2, they work in opposition. So if CO2 goes up, then the pH goes down, the percentage of hydrogen ion concentration, and the pH falling below normal is acidity, or your patient being acidotic. So CO2 level goes up, and the acidity goes down. It could be that they're compensating for acidosis. Hyperventilation, breathing extremely fast for an extended period of time, could result in alkalosis, or the pH going up, 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 and that is because of an excess of base in body fluids. Can also be a panic attack, and we see that in our business quite frequently. Symptom of a panic attack, hyperventilation, just due to anxiety, or due to an event that occurs around this person. They become emotionally upset, and they start to breathe really fast for an extended period of time. I'm talking for a long time. If you were to do that to yourself, like I just did, if you went much longer than I just did, you start to get dizzy. And that dizziness worsens the anxiety. So the hyperventilation becomes worse, and the dizziness becomes worse. And eventually, after enough CO2 is enough excess exhalation of CO2, the person starts to feel numbness around the mouth and nose. Their lips are really numb. And then, as if that wasn't bad enough, start to have a tingling feeling in their hands and feet. And that eventually progresses to these horrible muscle spasms in the hands and feet. And I've seen patients in horrendous pain from that. And they're breathing too fast, and they have been for quite a while. They're dizzy. They have that numbness, and we need to do something for it. What do we do? In the old days, we had them breathe in and out of a paper bag. And then in EMS, we would put a non-rebreather mask on them without connecting it to the oxygen supply. Why would I say we used to do that, which strongly means we don't do that anymore? Why would we stop doing that if the rebreathing, because this person has blown off too much CO2, why would we want them to rebreathe more CO2? Because we wanted to raise the CO2 level up to the point that it started reversing that alkalosis, that respiratory alkalosis, and brought the needle back into the 7.35 to 7.45 range. And then the signs that we see and the symptoms that they convey to us have been reversed, and we're miracle workers. Remember, I said somewhere that could be an indicator of a life-threatening illness. So if that person has a life-threatening illness, such as diabetic ketoacidosis, and we threw that non-rebreather on them without connecting it to oxygen, which was extremely dangerous, by the way. Instead of treating that underlying condition that our patient has, we worsen their condition and we end up killing our patient. That's why we don't do that. Environmental exposure could be, if you've ever gotten a strong whiff of Clorox that you use in the laundry, it will take your breath away. Chlorine gas is far worse. We'll talk about that when we have a whole chapter on this environmental exposure stuff. Other gases, pesticides, all of those can interfere with oxygenation. Could be carbon monoxide. Carbon monoxide, remember 300 times, hemoglobin has, no, carbon monoxide has 300 times the affinity on hemoglobin as oxygen does. So if there's a toxic amount of carbon monoxide present, the hemoglobin is going to latch onto it better, hang on to it longer, and it's difficult to, for that, without some outside intervention, it's difficult, if not impossible, for that person to reverse that. And because person becomes disoriented eventually if they remain in that carbon monoxide, and they may not be able to self-evacuate to normal air, and so they're stuck in there breathing the carbon monoxide, and eventually it extends to the point that they die, I guess. That's the word I was looking for, death. Okay. Carbon monoxide's odorless, highly poisonous for the reason I just mentioned. It's produced in several ways, but fuel burning appliances like a gas stove, a gas heater in a house, smoke from a smoldering house fire. That could, somebody's asleep in bed at night, whole family, and there's a smoldering fire, and that smoke, there's carbon monoxide in there. Where does carbon monoxide come from? It is a byproduct of combustion. So the oxygen is used, and that leaves carbon monoxide, and it builds up to the point that it kills someone. Don't put yourself at risk. Let somebody with an SCBA go in and take care of that. All right, let's stand up and stretch for 5 minutes, and then I will go through the next chapter. And then I'll put this PowerPoint on Blackboard so you can access that. Work through the treatment of all this stuff that we just went through. It's straight up, straightforward. When you see what the treatment is based on what we discussed this morning, you say, discuss, dude, you just sat there and talked. We didn't talk back, so what discussion? Okay, things I've lectured on this morning will, based on the knowledge you gain from my lecture this morning, combined with reading the book, the treatment that goes with all of this as you work through the rest of the PowerPoint is going to be absolutely obvious to you. If not, shoot me a text or give me a call. Give me a call. I might not be able to answer, but I will call you back, and we will work through it. There's no reason to read through this every time with little bitty additions. All right, but there are highlighted areas in there that I want you to see. Stand up and stretch real big. Get some blood out of your legs so you don't have a PE, and let's cue up the next chapter. Oh, questions before I do that. How about that? Anybody awake out there still? Probably not. All right. Let's get another chapter here. Oh. Oh. No, 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 no. I like you, Dr. Beam, but I don't need you there. Okay. All these dang news things keep popping up in the lower right of my computer, and I can't make it to share fast enough. Now you should be able to see it. Oh, I didn't stop recording. I'll just talk to myself here. Nope, I kept recording. All right, everybody ready? Fasten your seatbelts. Here we go on medical overview. Medicine. Okay, we've had that slide multiple times. We need to start working on assessing and managing medical conditions versus trauma that we spent a bunch of time on in lab. Why? Because we hadn't been through the medical chapters yet, and I wanted you to get plenty of hands-on and start to internalize patient assessment, because that needs to come second nature to you. Pathophysiology assessment management of medical complaints to include what your transport mode will be and where in the heck do you take these people. We need to be aware of infectious diseases and communicable diseases that our patients might have. Communicable disease, again, is it can spread from person to person. I think they're using loosely infectious disease here because I think they mean it to encompass communicable disease also, based on what the rest of the chapter has. Remember that medical conditions and trauma conditions aren't mutually exclusive. A medical condition can cause trauma. Trauma can exacerbate a medical condition. Remember, exacerbate, that's that word that means make it a whole lot worse real fast. So exacerbate, okay. Man. And what do we remember about medical emergencies? We're talking about the nature of illness then, rather than mechanism of injury. So nature of illness, does our patient have a respiratory problem, a cardiac problem, cardiac and respiratory problem? Does our patient have a gastrointestinal problem? That's what we're talking about here. Let's just read these. Might as well. Respiratory emergencies. Patients have trouble breathing or the amount of oxygen supplied to tissues is inadequate. That sounds familiar. I just spent half a day on it, right? Cardiovascular emergencies, you're going to get half a day or more on it also. Caused by conditions affecting the circulatory system. Neurologic involves the brain and nervous system. I don't know why they didn't leave that in there. Gastrointestinal, anything from appendicitis, diverticulitis, pancreatitis, and so much more. Irritable bowel disease, I don't know, throw it all in there. Urologic, that's kidneys, ureters, bladder, urethra, that whole system. Again, I don't know why they stopped short, but I don't mind. Endocrine emergencies in our world, in EMT class, that's going to deal with diabetes, and we'll spend half a day on it, or half class period on it as well. Hematologic emergencies, that's blood, right? Hematology is a study of blood. But so for us, hematologic emergencies, mostly going to be sickle cell disease, and that's a problem with red blood cells and hemoglobin and their capability of carrying oxygen because of the morphology or shape of the structure, or it's going to be blood clotting disorders. Immunological, for us, immunological, when we do that lecture, that's going to do with anaphylactic reactions, severe allergic reactions, and then toxicologic emergencies, that's poisoning, substance abuse, and then GYN, gynecologic emergencies, female reproductive organs, urologic emergencies, that would be the urinary tract, and that would extend up to kidney stones that we'll talk about soon. Okay. And patients don't read the book. I'm telling you that the signs and symptoms that your patient presents with don't always line up with A, B, C, D, E, F, G of the signs and symptoms of having the epizooty. Their epizooty, they didn't read the book, so they've got like four signs and symptoms from our long list. Then they have signs and symptoms of other stuff. They just don't read the book, not at all sometimes. Okay, this chart's in your book. These are common emergencies, examples of condition on the right. Those are the things that we're called to assist with, and the system that's involved is in the left-hand column. Remember, this is nature of illness in medical cases, and then so after we've ruled out life threats and we've done a complete assessment of our patient, then we can focus more on their nature of illness, their signs and symptoms, and their chief complaint. Need to get an accurate medical history, dispatch dispatch information. Don't try to say information and look at the word response at the same time. Dispatch information can give you a good general idea of what you might be dealing with. Sometimes the caller does not convey the proper information. Sometimes the dispatcher does not properly interpret the information provided. So there can be a breakdown from the get-go that translates its way into the nature of call you're dispatched to, and you thought you were responding to a pediatric patient with a rash, and it ends up being a 51-year-old male patient with crushing chest pain, and it's radiating to his jaw and dyspnea, but he does happen to have a rash on his arm. There's breakdowns sometimes. Don't get tunnel vision. Don't get locked into what your preconceived idea of your patient's condition is and try to fit a square peg in a round hole. This is a good guideline or go by what comes from that dispatch information. But when you get there and everything is going a different direction, then go with that and evaluate it, assess it, and determine what body system is actually involved and what you need to do to deal with it. Some patients, medical patients, are uncooperative. Some are downright hostile. Some, it's because they're bad people, and then you shuffle an illness on top of that, and then it just makes them impossible to deal with. Sometimes a medical condition can take the nicest man that you would ever meet and turn him into an absolute monster. who is 6'6" and 250 pounds of solid muscle, and he can hurt you. So it's this, and then you're trying to assess him after he's restrained and on your cot, and you're trying to assess him and he still wants to kill you. It may be difficult to do a good, thorough assessment. But even in the face of hostility and lack of cooperation, you must maintain a professional, calm, and non-judgmental demeanor. Keep your stuff together, even when your patient's losing his or her stuff. I'm saying stuff because I'm not going to put the other word in there, but and what do we call that? Sometimes that's de-escalation. Maybe this person is scared to death. Maybe this person's grandmother died of what your patient perceives to be the same thing that's nailing them now, and they're just out of control because of it. That's what you're dealing with, and you can de-escalate that situation by being calm. Don't judge them as a total jerk who wants to kill you. Be professional. It's your job. It's your job to keep your stuff together, assess, and treat your patient. Nobody said it was going to be easy. All right. And like I said earlier, hypoxia, that not getting enough oxygen to the brain, that cerebral hypoxia can trigger some of this hostile, out of control, uncooperative demeanor. So we have to assess and determine whether or not that's the case and treat accordingly. Don't label patients, oh, he's just no homeless maggot. He lives in the alleys down there. He won't even go to the shelter because he can't take his booze and dope in there. And I just insinuating he's just no piece of crap who doesn't deserve medical care. Happens to be a human being. Maybe he doesn't smell so good, but at least at some point in his life, he was somebody's little bundle of joy, a cute, sweet little baby. And through probably a horrible series of horrible events, or a long series of horrible events, wound up being the man you see in front of you. So treat that patient with the same level of respect and dignity that you would the mayor of Amarillo, if you ran a call on the mayor of Amarillo. Just because they're a frequent caller, they call every other shift. Seems like every day you work, you respond to this person, they have a different complaint every time. That doesn't mean something real isn't going on right now. So you need to go back to being professional and assess that patient like you would any other patient. And they may have a totally different problem this time that's going to kill them if you're unprofessional and you don't approach them as you would any other person, any middle-class person who smells good, drives a nice car, lives in a pretty good house. Sometimes that's hard. I'm not going to lie to you. It's not always easy, but if you want to be a professional EMT, a healthcare professional, then you're going to assess them completely every time, just like you would anybody else. Scene size up, scene safety hasn't changed. It's the same. I'm not going to read it to you. Determine the nature of illness, then develop this might be fairly new, this phrase, index of suspicion. Must be, because they took time to define it this time. Nature of illness, even mechanism of injury. Today we're talking about illness. Nature of illness gives rise to your index of suspicion as to what their underlying problem is. So index of suspicion, your awareness of potentially serious underlying injury or illness. I'm going to take it a little bit different. Index of suspicion, if your patient has their fist clutched to their chest like this, and they're having shortness of breath, and they're pale, and they're sweaty, that gives rise to your index of suspicion that your patient might be having cardiac chest pain. So that is the body system that's involved. So that's an example of nature of illness. Then you're going to develop a general impression, just like we did when we talked through patient assessment, right? Is this patient sick or not sick? Sick could include injury, but it's sick is an emergent patient. That patient that we reassess every 5 minutes, that is that about to die, extremely sick person. That is our general impression. Sick, not sick, critical, non-critical. Airway and breathing, we assess those the same as we always have, right? As we get our vital signs, remember we've talked about that ventilatory rate includes a lot more than counting respirations. It does include the rate, but it includes the depth and the qualities, quality labored, non-labored. So rate, depth, and quality, and let's add rhythm, rate, depth, and rhythm, and quality. That gives us a quick idea that our patient has a respiratory issue that we need to deal with, if possible, right now. If that patient's having problem with the rate, depth, rhythm of respirations or quality, we need to supplement oxygen. How much? I don't know. How sick are they? And what do we have available? Well, I have this non-rebreather and I got my full tank because I inventoried my truck this morning and I know that I have 4 full D cylinders of oxygen. So, and then I have that great big M tank that's strapped to the inside of a cabinet in my exterior compartment in my ambulance. So I got lots of oxygen. So I just need a delivery device and I determine the appropriate one. And we get oxygen on these patients. All of our patients who need oxygen, we get oxygen on them early, right? If they're unconscious, we need to protect their airway. We need to open their airway. So open would come first. So we need to get an oropharyngeal airway in there if they'll tolerate. If not, if they have a gag reflex, we're going to go with an NPA unless they have facial trauma, right? So we're going to make sure they have an airway. Then we're going to deliver oxygen to all patients in shock, all patients with difficulty breathing, and all patients who have a low SpO2. That is the pulse oximeter reading, the little finger clip that gives you a number. Know what that number is and what it means. All patients. So we established early on in this course that 94% was our minimum, right? So if that's the indicator we're using to determine whether or not to administer oxygen to our patient, we're going to watch that. If it's 94 or above, we don't need to provide supplemental oxygen. If it's below, we need to manage it. And unconscious patients or patients with difficulty breathing and signs of poor perfusion. So if they have problem with their rate, depth, rhythm of respirations, we need to bag assist them. That's positive pressure ventilation, assisted ventilations. with the bag valve mask. And we talked about that bad boy earlier. You've used one, right? What do you mean talked about it? I've used that sucker. Circulation, we need to assess not just their pulse and the rate and rhythm of their pulse and the regularity of their pulse. We all and the characteristics of their pulse. Is it strong and bounding? Is it weak and thready? We also need to assess skin color to give us an idea of how well they're being perfused. So checking capillary refill in the fingers is always a good go-to. So push that nail bed down till it turns kind of a white color and let go. It should go pink again before you can say capillary refill. That very valuable tool in pediatric assessment for circulation and respiratory system. And for unconscious patients, we're going to get a carotid pulse. Transport decision, we're ready, right? Is it right now, got to get help, emergency, or can we take our time, stay and play, and not put ourselves and our patient at higher risk of a motor vehicle collision during transport with lights and sirens? Because people do bizarre, crazy things when they see lights and hear a siren. For instance, they've pulled your in traffic lights and siren, and you are approaching them not head to head as in head on, but you're in your appropriate lanes, you're approaching one another, and they pull to the right and slow down. Oh, great, that's what they're supposed to do. And then they accelerate across 5 lanes of traffic on Western Street with the turn lane. So they accelerated across the turn lane and the 2 inside lanes, and then they pull over and stop at the wrong curb. Why? I don't know. Just people go stupid when lights and sirens are involved. So if you don't have to transport your transport your patient to the hospital because they have a life-threatening injury or illness, don't run with lights and sirens if you don't have to. I guess that's what I'm trying to say, because it is much more dangerous. That's not saying if you have a critical patient, we're not going to run them in with lights and siren, because we are in most systems. There are a few EMS systems who are doing away with transporting patients to the hospital with lights and siren, commonly called code 3. And then there are even others who are doing away with a response with lights and siren, and supposedly have statistics to back all this up. We're going to get a sample history from our patient, right? Or if the patient can't provide the history, family, friends, bystanders, medications in their little bag that they have with them, medical alert necklace or bracelet, whatever we have available to us. If there's pain, we're going to get the OPQRST, but sometimes we're going to do part of this. So, no, never mind. That fits with pain, with chest pain. Sorry, I'm getting tired here. Note any allergies. If your patient has a penicillin allergy and you're getting your sample history, they tell you they're allergic to penicillin, they've had an anaphylactic reaction to penicillin, make note of that and convey that information. It could be that they become unconscious, unresponsive, because their bacterial pneumonia is so profound that it takes them down, and they don't have a medical alert bracelet. They don't have anybody to convey that information but you. And let's say they have a horrendous allergy to penicillin, but the hospital doesn't know that. So they start an IV antibiotic that is one of the Cillins. There are a bunch of them, but it's one of the Cillins, and that patient who's already compromised has an anaphylactic reaction because they were receiving penicillin, due to the fact that nobody in the hospital knew about that allergy. If that patient's conscious and talking to you, it is noteworthy to get to obtain allergies, write those down, and convey that information, because you may be the last human to interact with them before they became unconscious, unresponsive, and you could, in the future, save their lives because you spent enough time on A in sample history. All right. There are medications that are incompatible with other medications. That's M. We need to try to obtain a list of medications from our patients, or take their little bag of pills that they carry around with them, like my mother. You ask her what she takes. Now she has a list, because I finally nagged on her until she made a list that she keeps in her purse, in her little bag that she carries all of her medications in. She has a list tucked in there that has her allergies, and it has a list of all those medicines. In the past, and Mom has a meningioma. It's a tumor of the meninges, that that protective layer that goes around the brain and the spinal cord. She has a meningioma. She has a brain tumor in the meninges, and every now and then she has a major exacerbation of something or other with that, and ends up going to the emergency room and occasionally admitted to the hospital. And up until 18 months ago, if you asked her what medication she took, she'd say, "Hand me my purse." She'd get out her bag and boom, drop it on the table, and then you went through. And now there's a list. It's still in that bag, but I have a picture of it stored on my phone. All right. Allergies, medical conditions, medications, very important. If your patient is like my mom and they take a bunch of medications, make sure you take their little bag with you to the hospital, and assure them that they're going to take care of your property at the hospital, and they will. They'll lock it up. They might lock it up so good nobody will ever find. No, don't tell them that. They're going to take care of your medications. We need to take them to the hospital to make sure somebody doesn't give you something that's going to kill you. Let's add a new acronym. I know what an anachronism is, so I guess there must be an acronym. All right, we're going to add a new acronym here. In getting a patient history of a medical patient with a medical complaint, we're going to add tacos to the mix. I love tacos. We don't just do this on Tuesday for Taco Tuesday. We need to inquire as to tacos with our medical patients every time. Use tobacco. Yes, no, it's an easy answer. Used to smoke up until 25 years ago. They're going to tell you that, but that's not what you're after. If they say they smoke, what do they smoke? How much and how often? Excuse me. Alcohol. Some little old ladies, like my grandma on my dad's side, she was horribly offended if when she went to the doctor or the hospital and they asked, "Do you drink alcohol?" And she would get furious with them. "Well, don't they know I've been a Baptist Sunday school teacher since I was 18 years old, and I never had a drink of alcohol, and I don't know what to make them think I'm a drinker." And you couldn't convince her, especially after she was an old woman. You could not convince her that they ask everybody that, but ask that at the risk of upsetting somebody's nanny. That was my nanny. She got offended by, if you ask about tobacco or alcohol, she just went bergerac, as Nicole's father-in-law was the first person I ever heard say that, because that's the way we said berserk for the fun of it at AMS back in the old days. Caffeine, ask about caffeine. Do they drink caffeinated drinks? What do they drink? How often do they drink it? you can conceivably drink enough coffee to cause you to have a coronary artery spasm, which results in a myocardial infarction, which results in cardiac chest pain and maybe even death. It is possible. Let's shuffle in there. I had a couple of cups of coffee. Then I drank 6 of the biggest, baddest hot dog, hot shot drinks on the market out there. And it's, what am I trying to think of? This happens when I get tired. Like Monster and those things. Monster does, there are things that'll put Monster to shame, but especially in adolescent males, they love to drink 4 or 5 of these, two, maybe 3 or 4 of these before they go work out or before they go, I don't know, whatever they do. Too much caffeine, caffeine is a drug. Too much caffeine can cause big problems. So let's find out about it. Over-the-counter medications and herbal supplements, and then sexual enhancement drugs and street drugs. You're going to piss some people off asking about those 2. Ask it. It's your job. If it pisses them off, that's their problem. But don't just let them get pissed off. Say, we have this thing called tacos. It gives me a list of things I need to ask about with every patient. And so that's why I'm asking you. And if you don't take them, fine. Most people don't, but every now and then I find somebody who does, and it can be a big deal in managing them as patients. So if you don't mind, or maybe if you do, I have to ask again, do you take any sexual enhancement drugs? All right. Well, I don't know. Ecstasy, I mean, you're 85, but ecstasy, I don't know if X is a street drug or a sexual drug. I think it might be both, but yeah, it's pertinent that you take that stuff. I don't think there is, back on sample history, the appropriate place to plug that in. So that's why we do this. All right. Secondary assessment in a critical patient is done en route to the hospital, right? Done on the scene if you have time, if they don't have a life-threatening condition. My method differs with the book here. All conscious patients should undergo a limited or detailed physical examination. Somewhere in that dang book, it says you just go to a focused exam from the start based on chief complaint and medical history. Don't do that. Always assess motor, sensory, and circulatory, and all 4 extremities right on down the line. Let's do at least a modified assessment of everything. I'm not talking you have a speculum and a light and you do a pelvic on people. Don't ever do that. That is outside your scope of practice as an EMT. Unconscious patients, they always get the full meal deal. They get a detailed head-to-toe physical examination using that algorithm, because we don't know what their life threat is, so we have to go find it. So you know how to do that secondary assessment. Let's add in now, which you already have in your algorithm, let's add in blood glucose level, BGL. If you have a standing order for it, or you get online medical control to poke a hole in somebody and get some blood, run the analysis on your glucometer, and then get a pulse oximetry reading, complete your assessment. If you find a life threat and ALS is available, call for ALS to meet you on the way to the hospital or come to your scene. That could include a helicopter. Always reassess every 5 minutes with your critical patients, and document, trend those vital signs, and primary survey, trend the condition of your patient, which means document each reassessment, what has changed, and keep track of that. We're almost up to 11:30, and I will keep recording till I hit the end of the slideshow. If you need to go, you can just come back and fast forward to almost the end and jump in here. I apologize for being so long-winded, but that respiratory chapter, that most of the time, respiratory seems to be what EMT students fail on the National Registry. That's why I spent 3 hours on it. Okay. And then most of our patients with medical emergencies, they're gonna require definitive care. We're not gonna cure them. We're going to try to stabilize them, deal with life threats, and get them to the hospital. It's not our job to diagnose everything going on with them. That is what they do outside the ER, really. The ER is just extending that assessment for life threats, and they pick up other stuff on the way. It's going to require lab, x-ray, CT, ultrasound, all kinds of things at the hospital to arrive at a diagnosis, the definitive diagnosis. We're just trying to patch them up and hold them together and keep them alive till we get them there, right? Okay, that's beyond our scope of care. But consolation prize, you can use an AED. I think that's hilarious that they threw that in there, but it's extremely important. If your medical patient starts crapping out on you, what does that mean? Their level of consciousness starts deteriorating, their vital signs start deteriorating, they are going down, they are fixing to die, as we say in Texas. They're fitting to die, they're FTD. Remember your AED. Get that sucker out, have it ready, because the rapid administration of appropriate electricity, which is what an AED does, in appropriate heart rhythms, ventricular fibrillation, ventricular tachycardia, early, like as fast as we can do it, that you have a much higher percentage chance of converting that rhythm to a perfusing rhythm away from that end of life rhythm. It's more than life threatening. It's going to kill them. It's going to kill them fast. So if we defibrillate them with that AED, we have a much higher chance of converting them when they just went into arrest, cardiopulmonary arrest, than what we do if that goes on for a while. They get super acidotic. There are multiple things against them that getting worse and worse. So if we can defibrillate them early, we may make a big difference for them. Scene time could be longer for a medical patient. Still, I'm telling you, if you have a critical patient, don't play doctor on the scene. And but by playing doctor, I mean trying to diagnose them and going through all this detailed global medical history, rather than getting the history of the present illness and whatever is part of the life threat we're dealing with. That's our job. We need to recognize life threats, treat those, manage those, and transport them to the appropriate facility. Take into consideration the age of your patient. If you have a pediatric patient, you may transport to a pediatric, the emergency department at a pediatric specialty hospital, and you may drive right past 2 trauma centers on the way. Lights and siren, not lights and siren. Life-threatening, not life-threatening. Just talked about those. Keep in the back of your mind the possibility of helicopter transport. Or let's say you're an EMT in, oh, good Lord, let me pick a, let's say Springer, New Mexico. You're an EMT in Springer, New Mexico, and you have a critical patient that they want to send to a hospital in Las Vegas, New Mexico. It's bigger. They can do more stuff. and then they could transfer them on to Albuquerque or Santa Fe or maybe even Amarillo or Lubbock. But you're going to bounce along in a ground ambulance for, depending on conditions, 2.5, 3 hours. Maybe it's a 90-minute drive normally, but maybe you had snow and the roads are slick, but it's cleared up. The as far as visibility and flying weather, but they're giving you this ground transfer. It is appropriate. In fact, I think it's incumbent upon you to ask, is there a reason that we can't send them by helicopter? And they may jump on your butt and be really rude when they tell you the 10 reasons that they can't transport this patient by helicopter. Or maybe they were so busy and so focused on managing stuff that it just slipped their mind and they didn't remember that maybe this patient could fly now. Or maybe the snowstorm was raging that morning when they got to the hospital, and we're in early evening, we're 6 o'clock, maybe 12 hours later, and the skies have cleared and the storm has moved on through. Now that helicopter could fly when it couldn't before. So it is appropriate. from a person to one person. Approach your medical patient like they're a trauma patient and follow that same algorithm, except for you have nature of illness. Symptoms going all there are tons of other diseases that are endemic in those tropical regions, meaning they're there all the time and it could be easy to contract them. So travel history becomes important. A few years ago, well, this isn't gone. Ebola is not gone from West Africa. We're just not hearing about it as much because they've gotten better at treating it with some of the same medications that they're using to treat COVID-19 because of their antiviral and anti-inflammatory properties. So there are people in West Africa still dying from Ebola. So travel history going along with signs and symptoms can tell a story that you would never get if you didn't get information on travel history. Could be that travel involved scuba diving in the Florida Keys and then immediately hopping on an airplane and flying back home to Amarillo, and that your risk of developing the bends goes up enormously when you fly to high altitude after scuba diving without spending the appropriate time to acclimate your body following the dive. There are rules on that. If you're a scuba diver, I'm not, so I can't just spout those rules off, even though I'm familiar with it. Then we have to hone in on those life threats, and we need to do that in that primary assessment. What's going to kill them right now? We have to treat it. Let's see what's different. Put them in a position of comfort, keep them warm, transport them, use standard precautions. This should be way back there. We need to always protect ourselves and patients with infectious diseases. Epidemic and pandemic. Epidemic, new cases of disease in a human population in our world, human population that substantially exceed what is expected. If we're having more seasonal flu than we do in a normal year, if we're having a lot more of them in December than what we normally do, and if there's a high enough level, eventually we could say we have a flu epidemic even really early on in the flu season. Or if it's October and the seasonal flu cases are off the chart, we may have an epidemic. But if it is on a global scale, it's a pandemic. So when they say the pandemic all the time, when they're talking about COVID-19, it is a pandemic because of the global spread of it. Okay, influenza, it's a mammal respiratory disease. Yes, there's swine flu that somewhere back there, it doesn't have to be that it historically went from pigs to people, or that it went from pigs to people and it just stayed in people. There are animal influenzas that people can contract, and the swine flus seem to be one of the biggies. Then there is canine influenza. They say that canine influenza does not make us as humans sick, but we can carry it home to our dog. That's why they're recommending a canine influenza vaccine every year for your dogs now. Okay, I've never seen a case of the canine flu. I can't tell you much about how a dog presents with that. Okay. Recently, in 2009, that's not all that recent anymore, is it? We had an H1N1 flu pandemic that it was a swine flu. It normally occurs in pigs, and there eventually was a genetic mutation that in the DNA of that H1N1 influenza that allowed it to be transmissible to a human, and then we had sustained human-to-human transmission. And you used to hear a lot about the bird flu. Oh, good Lord, if that bird flu ever makes the jump, we're all going to die. Talked about that the whole 12 and a half years that I worked in public health as an emergency planner. And we had all these bird flu plans and all this stuff, and anything that might come along and kill us, we wrote plans for. Okay. N95 mask is what we wear, plus eye protection and gloves to protect ourselves. If we really want to be protected well, we could wear a PAPR, which has a HEPA filter, which provides much more filtration than an N95 mask. That's what you wear when you're coming in contact with an Ebola patient, normally is a PAPR. With that HEPA filter, it has a little belt, kind of a positive pressure device, a little pump that sits on the belt, and it sucks in the ambient air, runs it through that HEPA filter, and then blows it on into your supply hose that goes to your PAPR. Put a surgical mask, or there's a difference in a mask and a respirator, and it has to do with the percentage of filtration provided by that mask. Surgical mask is about as low as you can go. TB, you'll do fine putting a surgical mask on your patient, and you wearing an N95. And there are guidelines to go by. If you have questions, contact medical control, but always protect yourself. Get your annual flu vaccine, unless you've had an anaphylactic reaction to it, like me, and then you just get the flu every few years, like I did this past year. It sucked. Oh, the herpes virus, oh, these sexually transmitted diseases. We spend a whole chapter on those, so take a look at those real quickly. Hepatitis, that infectious process of the liver. Early signs: loss of appetite, vomiting, fever, fatigue, sore throat, cough, muscle and joint pain. And then you start to get jaundice. Their skin gets a yellowish appearance to it, and their sclera, the whites of their eyes, start to get yellow. And then they may have right upper quadrant pain because their liver's inflamed, and it sits in a fibrous capsule to help protect it. But that fibrous capsule keeps it from having a place to go as it swells. So they start to get intense right upper quadrant pain, and quite frequently that's going to refer to the right shoulder. Could be toxin induced. You could be working in a toxic environment that impacts the liver and causes hepatitis. Let's see, okay. Can't always tell if your hepatitis patient is contagious, so you always protect yourself. Stay up to date on so if it's wet and sticky and ain't yours, you got to protect yourself from it, right? Wear the appropriate PPE, and make sure your hepatitis B vaccine is up to date, and I am helping you do that before I can send you to clinicals. Okay, there are the different hepatitises. There are multiples. Meningitis, that's an inflammation of the meninges, that protective layer around the brain and spinal cord, and that signs and symptoms. It can either be bacterial or viral, and that triggers that inflammation. We'll talk more about it later, much later, but the signs and symptoms: fever, headache, stiff neck, clinically known as nuchal, N-U-C-H-A-L, nuchal rigidity. Their neck is stiff, and if you have them lying on their back and you tip their chin down toward their chest, they'll raise their knees up, and then if you flatten out their legs, they'll raise their head up, because that inflammation in the meninges that covers all that central nervous tissue, it pulls pressure on that, and it hurts really bad. So just kind of a reflex move. They raise their head if you flatten the knees out. If you raise the head, they'll bend their knees. Come to paramedic school, and we'll give you names for those, but you don't need to worry that much about it right now. Then altered mental status. Eventually, that headache is an intense headache, very intense headache. Meningococcal meningitis is highly contagious. Take standard precautions, including an N95 mask and a mask on your patient. What's the problem with putting a mask on your patient? I can think of a couple. Number one, you can't see if their lips start to become cyanotic. Next, if they suddenly start to vomit, not only do you have to get an oxygen mask out of the way, you have to get that mask out of the way so that they don't, it doesn't hold that in their mouths and they aspirate. But we still need to strongly consider putting at least a surgical mask on them and wear a mask ourselves. That's 2 layers of protection, right? And anytime you treat a meningitis patient, notify the your infection control officer at your job. How am I going to know? Sometimes you know because the diagnosis has already been made and you're transferring the patient. Sometimes you have a suspicion that it's meningitis, or you transport somebody who just has a headache, and it turns out after they do diagnostic procedures that they determine that it's meningitis, and they will contact the hospital, will contact every person who has come into contact with that patient, or the health department will contact every person. And then there's prophylactic medications that you take to protect you. TB, you can have TB anywhere in your body. We normally think of the TB in the lungs, and that's what really we're talking about here. But when a patient has an active case of TB, as they cough, that bacteria is spread around in that aerosol, in those droplets, and breathing that in could be how you contract TB, or your body could just form a tubercle around that bacteria, these little cystic things throughout the lungs, and there it sits until another infection comes along, such as HIV, and then boom, that TB becomes active when that person never had a symptom before. All right. Respiratory tuberculosis is the contagious form, even though you can get it throughout the body. N95 mask or a HEPA filter mask. HEPA filter mask could be the one with just a little cartridge off to the side, or maybe 2 cartridges up to that papper with that HEPA filter on the belt, where that belt pump is. It's more like a fan, a belt fan, that constantly delivers filtered air that's been through that HEPA filter up into a hood type thing that you wear underneath your Tyvek suit with taped up seams and gloves and boots and the whole 9 yards. But okay. There is no absolute protection from the tubercle bacillus. Bacillus is a bacteria. There's no absolute protection. It floats around in the air to the point that 1/3 of the world's population is infected with TB. And this is an old book. It's more than that now. In the US, we don't receive a vaccine for that, because that vaccine is in large part ineffective. They still use that vaccine in Mexico. So if you have someone who was born in Mexico and came to the US, they may have received that vaccine. Why is that even relevant? They have to have, you can't do a TB skin test on a person who's had the TB vaccine and get an accurate TB skin test. Takes a chest x-ray every time, or a lab test that's definitely not done in ambulances. Okay. It's not highly virulent. It doesn't transmit from person to person extremely easily. It takes quite a bit of that bacteria to cause someone to become infective. Stay on top of it. Get your TB skin tests. Pertussis, that's a whooping cough. For the most part, it's going to cause kids under 6 to become ill or even die. Older than that, we're going to be carriers of it up until you get to those elderly folks in the nursing home, and those elderly folks in the nursing home or at home. Oh, the old people demographic. I am rapidly approaching that, I guess. So us old folks are susceptible to whooping cough killing us. So it's good to have the vaccine and the boosters, right? If you're going to be, if you haven't been around little kids, seems like forever, and you have a new grandbaby coming, or you have a new niece or nephew on the way, or maybe you're, I don't know. Anyway, you're going to be around little kids. It's good to go ahead and get a booster and get it far enough in advance, like 30 days before being around the kids, so that protects them. What do we call that? Herd immunity. If enough people in the herd, even a small herd, are immunized, that baby who can't be, good Lord, I think it's 6 months, maybe 3 months or 6 months when they get their first pertussis vaccine. So they're working off mom's immunity between birth and that 3 or 6 months, whichever it is. And that's pretty strong, but it starts to wane or go away after a while. And if you interact with that kid in that little window, you could be the one that brings pertussis to them. So you stay up on your DTPs and everything will be fine, or Tdaps or whatever they're given this week. But TD, tetanus and diphtheria, doesn't cover it. Why? The pertussis is missing out of it. MRSA, take a quick look at that in the book. It's treated with IV antibiotics. It's an antibiotic resistant Staph aureus bacteria, and it just proliferates and it doesn't respond to the normal antibiotics, and they have to go to the big guns, or some different guns at least. Middle Eastern respiratory syndrome, coronavirus, it should sound familiar. It was just a different strain of coronavirus that back in around 2011, 2012, 2013 is when we first heard of it. And we had a great fear in public health at that time that we had the next go around of a different coronavirus. Coronaviruses are fairly prevalent, and they can rear their ugly heads and attack a population like COVID-19 has, or it can just sit there and cause a few cases occasionally, and we don't really think that much of it. Ebola, it is a viral hemorrhagic fever. There is a 21-day incubation period between exposure and up to 21-day incubation period. So up to 21 days, somebody who was exposed to Ebola could begin presenting with these signs and symptoms of the active Ebola infection, but more likely the incubation period 6 to 12 days. Comes from West Africa. Pretty sure that somehow it made the jump from bats to humans. That should sound familiar right now also. And fatality rate approaches 70% with Ebola. If ICU treatment is not initiated promptly, even with ICU treatment, it has an extremely high mortality rate or fatality rate. So travel history is very important. Somebody has has a medical, they present with a medical complaint. And as you are getting a history, you get your sample history, you get your OPQRST, you pull in your tacos, you've remembered all three of those. Don't forget to ask about travel history. Have you traveled outside the US recently? Where did you travel? How long ago were you there? When did you come back? Where have you been since you got back? Becomes a dang important question. So, and you've heard about this stuff on the news with this COVID-19 stuff. Of all the EMT classes I've ever taught, you probably know more about communicable diseases and even travel in the interplay of travel medicine along with that than any class I've ever taught. So congratulations. All right. So if you have a sick patient with a recent travel history, put a mask on the patient. Then after you've put the mask on the patient, and you hopefully you approach them with a mask on yourself. Right now you would, right? You go in with an N95 mask and gloves and a paper gown. If there are any in captivity, you go in and you immediately you assess for life threats, but you immediately get a travel history. And then if that travel history, if they have a travel history, then we get a mask on them. That helps to prevent the spread of droplets if it's changed frequently enough, and it's not just a piece of cloth. That'll catch some droplets, but anyway, and then you get as much information from them as you can. Where did you travel? Did you get any vaccinations before you traveled? Do you know if you were exposed to any diseases, infectious diseases, communicable diseases while you were gone? They won't know the difference. You're just now learning the difference. So were you exposed to any sick people while you were there? That helps, right? Infectious diseases, I don't know. Were you exposed to any sick people while you were there that you know of? Is anybody else from your travel party sick that you know about? What kind of foods did you eat? What was the source of any drinking water? If they say they drank water the whole time, was it bottled water? Did it come out of a tap or a local well? Where did the water come from? Okay, extremely important to assess our medical patients, treat life threats, of course, but it's important to do the normal things, get your vital signs, all of that, manage life threats, but we also need to get a really good sample history. We need to cover OPQRST as it relates to our patient's chief complaint or any pain that they're having also. And then we need to get a TACOS history. So follow that TACOS acronym, get that history. Then we need to get the travel history. So there's a lot more history taking with medical illnesses than there are with trauma. Why is that? Because so many different things can cause it. So many different things can cause the same symptoms that we really have to cover the bases to determine sometimes even what body system is involved or what body systems are involved, so that we can look for and manage life threats, so that we get that allergies history that they definitely need at the hospital, but your patient becomes unconscious, unresponsive. They're fighting just to keep them alive. Oh, we have them alive, put them on the ventilator. You know what? We probably need to give them some IV antibiotics, and then they're allergic to it because you don't want it to be because you forgot to ask. It may be that we don't get to find out either. But so that's this is all about still finding life threats, managing them, treating them without making our patient worse. We do that with our focused medical assessment. Once we've moved past immediate life threats, engage those acronyms that we have to help you learn, to help keep you from omitting an important point in patient history. And then we treat our patient and we stabilize them, transport them to the appropriate facility for definitive treatment. Sure, you feel like I left you hanging in the air today because you didn't learn a lot about all these things. We're going to break this down and we're going to have a chapter on all these medical conditions, and we will bring back in the signs and symptoms and treatment as we go through that. So thank you for hanging with me for an extra 40 minutes. Have a great day.
Hey, buddy.
Hey, yes, sir.
So our next test, is it Wednesday or Monday?
Oh man, I should have looked at the calendar. Let me grab it. I think it's Wednesday.
I've got one right here.
Let's see, today. Yeah, there'll be an exam Wednesday over the 2 chapters from today.
Okay, 14 and 15.
Uh-huh.
And then will there be a quiz on that same day?